severely diabetic patient, post coronary artery bypass surgery, came with an acute coronary syndrome with occluded grafts to the RCA and an occluded graft to the diagonal. Required multi-vessel drug-eluting stent. We cannulated the right coronary with 6 French JR 3.5 guide catheter and crossed the lesion with a BMW wire. You can see the diffuse nature of the coronary artery disease with multiple fibrotic calcified ectatic lesions throughout the length of the right coronary artery. Dilated the lesion with a 2.5 by 12 splinter balloon, and multiple inflations are being made throughout the length of this diffusely diseased coronary vessel, which is very ectatic, calcified, and needed high pressures to dilate the lesion. This is post balloon dilatation. This is a 3 by 33 biomime which I advanced and deployed at 12 atmospheres. You can see the biomime being advanced very easily through this ectatic, calcified, and fibrotic lesion, very easily, and deployed at 12 to 14 atmospheres. A second biomime stent is now being seen. I'm passing it. It's a 3.5 by 33 biomime which is being placed and deployed at 12 to 14 atmospheres. It is overlapping the distal stent by 2 mm. In the proximal segment, you can see a small flap which is seen between protruding out. High pressure balloon was used. A 4 by 20 sprinter a non-compliant high pressure balloon is being used to post dilate both the stents, specifically at the junction between the two stents. So here you can see the junction being dilated at 14 to 16 atmospheres, and this is the proximal segment which is being dilated almost at 18 atmospheres, and this is the final excellent result of the artery. This was the left coronary, which was cannulated with a 6 French JL 3.5 guide catheter, and the stenosis is being crossed with a 0.014 BMW wire. It's a medium support wire, and the lesions, this is the wire which is being placed distally into the big size diagonal to which a bypass graft is occluded. You can see a 2.512 balloon which is used to dilate the fibrotic calcified typical diabetic lesion. Multiple dilatations are being made throughout the length of the vessel. You can see the proximal marker and the distal marker of the balloon and the placement of the balloon within the lesion. This is after balloon dilatation. Here you can see the post balloon dilatation. This is a 2.75 by 28 biomime drug eluting stent which is being advanced, but difficult to advance it on the BMW wire. This is due to lack of guiding support and also because the lesion was very calcified. So a second buddy wire is being used. This is also a BMW wire which is placed distally, and a balloon dilatation is done at high pressures, and then you can see the biomime easily passing through this particular tortuous bend into the calcified lesion and well placed at the site of the stenosis. It's a 2.75 by 28 biomime being placed in the proximal and the mid segment of this diagonal artery and being deployed at 12 to 14 atmospheres. This is the result, and then the biomime stent is being dilated with a 3 by 12 non-compliant balloon at high pressures of 16 atmospheres. This is basically to oppose the strut of the stent well on the arterial wall. It is like a poor man's IVUS. Post dilatation, you can see the excellent final result. Though the nature of the disease is more diffusely diseased vessel because of the long-standing uncontrolled diabetes in a post coronary artery bypass patient with occluded grafts.